Hi everyone, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha and I am a nurse here at UWorld. Thank you so much for joining today. I'm so excited to see you. I know that you may be in the middle of your semester as nursing students. You may have already taken those midterms. We're kind of getting into the meat and the really difficult part of your semester, but good news, we are covering a super important topic today that I think will help you out, and that is electrolyte balance in the body, specific to potassium. So a super important topic. We're going to have a couple of questions sprinkled through just to test your knowledge as we go. And then to note, per usual, we're going to have our NCLEX style questions at the end. So make sure you stay tuned for those. They're a great knowledge test of what we've learned here today. Today we are back in studio. If you joined us last Tuesday, we went live from the Florida Student Nursing Conference in Orlando, Florida, which was a lot of fun. I hope you were able to check in on that one. But now we're back to our normal studio here back in Texas, and we're happy to have you guys today. All right, a couple of housekeeping things before we get started. We do always take into account the topics that you guys want to see, so make sure you're dropping in the chat. Let us know what lecture topics, what systems and body systems you all want to see us give more content on in the future. We are here to help you, so let us know how we can best do that. Today, you're also able to message us the word schedule to get a link to our events page for the events we have planned for the next 3 weeks on our social media, and you can also message us free trial if you would like to get a link to our free trial. We want to get you guys plugged into our platform, however that's going to look like for you guys. So a reminder that this live will be on demand on both Facebook and YouTube for future reference. So you can always check back in on it when we're done. If you're ever coming across this topic when you study in the future, you're able to drop back in and use this as a reference. As always, drop your comments and questions in the chat. Nurse Jackie is moderating, and we also have a new nurse, Nurse Brittany, who is moderating today. They're excited to hear from you all. So go ahead and drop your comments, your questions, and of course your answers in the chat below, or just stop by to say hi. We're always happy to hear that. So let's get started today in the chat by just warming it up. Let us know where everyone is joining from. Who here is joining from the US? Who here is an international viewer? It's so interesting for us to see this and hear this, so drop in the chat where you're joining from. Alrighty, so we're going to start with a little something different today, but we actually have a test plan image. This is taken from the NCBSN, or SBN, excuse me, I always mix that up, website, who are the makers of the NCLEX. They give great resources for nursing students to review prior to the NCLEX to see what's on it, what's going to be tested on, really what are the big client need categories that they need to make sure they're current on. And because we're covering electrolyte balance, I wanted to include this today. You can see underneath the client needs category, it shows manage the care of the client with a fluid and electrolyte balance, just to drive home that today's topic is so important. You will be tested on it in the NCLEX, and that's why we wanted to spend extra time breaking down electrolyte balance into the different electrolytes. And of course, today we're just going to be covering potassium. So speaking of potassium, let's go ahead and get started. So what in the body does potassium do? Why is it important? Potassium is pretty much like the MVP of our electrolytes. It does a lot of things in the body. So it's an important intracellular ion, meaning it mainly lives inside of the cells, and its role is to help control fluid volume inside of the cells. So I don't want to go too far into the weeds of things. I don't want to get too chemistry heavy, but quickly let's go ahead and summarize the sodium-potassium pump and what the sodium-potassium pump does in our body. So the sodium-potassium pump is a critical protein. It's found on the cell membrane, and what it does is used to create the action potential of a cell, which pretty much does exactly what it says it does. It's the potential. So it's slowly preparing the cell to be able to do its job. So think of the pump like this. So it's going to open to the inside of the cell and grab those first 3 sodium ions, which are positively charged ions. The pump is like, great, okay, we have what we need. I'm going to push you guys outside of the cell. And in return, when I do that, I then need 2 potassium ions. So the pump then picks up 2 potassium ions from the bloodstream and pushes them inside of the cell. And to note, potassium is also another positively charged ion. So the really cool thing here is that the sodium-potassium pump, it forces these electrolytes to an area of a higher concentration. And to do this, it requires energy, or in this case, ATP, to be able to do this. So in sodium's case, sodium is moving from the lower concentration in the cell to a higher concentration outside of the cell. It's essentially swimming upstream. It's like a little salmon. And potassium is moving from the lower concentration outside of the cell to the higher concentration inside of the cell. Again, it's swimming upstream as well. And this is a process called active transport transport because it's requiring energy. All right, so the biggest takeaway from all of this is that the exchange of sodium and potassium is super important when it comes to our muscles and our muscle function. The ions moving in and out of these cells is what's helping our muscles to work correctly, to function, to be able to do the things that we need to do every day. So this is especially important when it comes to cardiac muscles, and hint there, remember cardiac muscles, that'll come into play later, skeletal muscles, as well as those smooth muscles of our GI tract or the gastrointestinal tract. Alrighty, so knowing now that potassium should live in the higher concentrations inside the cell, let's talk about the normal range for potassium. So again, high serum potassium is going to be hyperkalemia, and low serum potassium is going to be hypokalemia. Again, a normal range of potassium is in that 3.5 to 5 milliequivalents per liter. So again, hyperkalemia will be values greater than 5, and hypokalemia will be values less than 3.5. But the good news here is that the NCLEX now gives us reference ranges on the NCLEX. So there's not as much need to be memorizing all of these lab values and reference ranges, because the good news is the NCLEX now provides that. So at least one thing you can kind of check off your list of things that you need to study. However, you may still need to be familiar with these for your nursing school specific curriculum or your clinical shifts, things like that. Alrighty, so now that we have a good base to what we're talking about, let's go ahead and jump into hyperkalemia, again, high serum potassium. So let's look at the causes of this. So if we have too much of anything, let's look at the big picture here. This means we either took too much in or we weren't able to get enough out. So essentially there's too much potassium in our bloodstream, our serum potassium is too high. Now, a couple of different causes for this. So this can be due to a large intake of potassium. It can also result from a client who came in hypokalemic or having too little potassium, and we went to replace those electrolytes and we over-replaced, we gave them too much, we flipped the problem, and now they're hyperkalemic. So this is one example of a clinical setting we can see hyperkalemia in. More than likely, though, clients who have hyperkalemia are probably going to be suffering from an impaired kidney function. So remember, potassium is excreted through our kidneys, through our urine, and in things like acute and chronic kidney disease, we'll have a decreased glomerular filtration rate or a decreased GFR, and this can cause hyperkalemia because we're not filtering the blood enough, we're not filtering out those excess electrolytes, that excess fluid, and this is where we get hyperkalemia from. Important to note is that we will be next week doing a chronic kidney disease lecture session. So this time, 12 p.m. Central Time on Tuesday, we'll be back to do a chronic kidney disease lecture. So if you have any questions about CKD or that's a little confusing to you, no worries. Join us next Tuesday and we will get you taken care of. Alrighty, so back to potassium and hyperkalemia. So we talked about kidney issues being able to cause hyperkalemia. We can also see medications put our clients into states of hyperkalemia. So potassium-sparing diuretics, they help us diurese, but they hold on to potassium. This can lead to an excess of potassium or hyperkalemia. Spironolactone is an example of one of the diuretics that's potassium-sparing. Other medications that reduce aldosterone secretion, such as ACE inhibitors or our pril medications, can also lead to hyperkalemia. Alrighty, in addition to medications causing hyperkalemia, there are also certain conditions in the body that can lead to high serum potassium. So the first one I want to talk about is DKA, or diabetic ketoacidosis. So in DKA, our body goes into a state of metabolic acidosis. And just a quick little refresher on this, but the pH scale is how we measure what's acidotic and what's alkalotic. And the pH scale is essentially a measure of the hydrogen ion concentration in our blood. So the more hydrogen ions we have, the more acidic our blood is. And to remember, potassium and hydrogen have a really direct relationship. So one goes up, the other follows, one goes down, the other follows as well. In DKA, we're experiencing metabolic acidosis. So we have a higher concentration of hydrogen ions in our blood, so we can expect to also see a higher concentration of potassium ions in the blood as well. Remember, it's a direct relationship. If they both go, one goes up, the other goes up. If one goes down, the other goes down. And in the same vein as DKA, hyperkalemia can also result from insulin deficiency or hyperglycemia. So in DKA, we do see extreme hyperglycemia, those really high levels of blood sugar. So these all kind of fit hand in hand. The more you get versed in really all of these, DKA, diabetes, kidney issues, they all are so closely interrelated. So when you see an issue with one, a lot of times you see an issue with the other as well. So remember, in DKA, we have extreme hyperglycemia, those super high blood sugars, and you may have already learned that insulin helps to move glucose from our bloodstream into our cells, to bring it in the cells. Insulin does the same with potassium as well. So when we have an insulin deficiency or low levels of insulin, as we will so often in diabetes, we have that low level of circulating insulin. We're going to have high levels of potassium outside of the cell because that insulin is what works to bring potassium back into the cell. So that's just a little refresher on diabetes too, which is a big cause of this. So other conditions that can cause hyperglycemia or hyperkalemia, include rhabdomyolysis and tumor lysis syndrome. So something that we're going to use as an analogy here is, let's think of our cells as balloons. We'll use a party analogy here. Our cells are balloons, and inside of our cells, potassium is like confetti in those balloons. So in rhabdomyolysis, we'll start there. Rhabdo is the breakdown of our muscles. So think of these as like the bursting muscle cells or bursting balloons. And since potassium is intracellular, it lives inside of the cell, when it bursts, that potassium confetti is going to explode and go all over and lead to higher concentrations in our blood, which therefore leads to hyperkalemia. Now let's use the same analogy to talk about tumor lysis syndrome. So clients who have a high cancer burden in their blood, when chemotherapy begins, those cells start lysosing or bursting. So those balloons start bursting, and that potassium confetti is going to be all over our bloodstream because it comes out of those cells. So tumor lysis syndrome and rhabdomyolysis can also lead to hyperkalemia. Alrighty, so we talked about the causes of hyperkalemia. Let's jump into what this looks like. What is the client going to present with? Okay, so when we think of hyperkalemia and our clinical manifestations of this, think weak muscle problems. So think of hyperkalemia like this. We know potassium should live inside our cells. If we have too much potassium outside of our cells, we can assume that the potassium tank inside our cells is running low. Our gas tank, our tank, if you will, isn't full. So instead of being able to operate at full capacity, at full speed, we're only able to really go half speed. The cells can't reach their full potential, and that's where we get these weak muscle problems. So remember in the beginning, we talked about the exchange of sodium and potassium, and that's super, super important when it comes to influencing muscle functions. I'm going to ask you all a question and include you in this now. What's an important muscle that is affected by hyperkalemia? I'm going to put this one out to the chat. So again, what is an important muscle in the body that's going to be affected by hyperkalemia? And I'll give you a hint here. We have an ECG strip slide, either showing now or about to show, but that's a good hint as what muscle I am trying to hint at. So I'll give you a few seconds to drop it in. And I already see some great answers coming in. Way to go, guys. But yeah, I see cardiac muscles. I see heart. Myocardial, wonderful. You guys got the gist. Way to go, you guys. I knew you could do it. So yes, when we think about important muscles affected by hyperkalemia, our first and foremost thing to think about is that heart. So when we tie this all together, if a client has hyperkalemia, we're going to worry about changes to the electrical conduction of the heart, which can manifest as ECG changes. So hence the ECG strip that we're showing for hyperkalemia. So high potassium can result in those tall peaked T waves, as well as the absence of P waves. A good way to remember this is K is the sign for potassium. When we have high K, we have high T, or those peak T waves. We can also see prolonged QRS complexes here, and this can also lead to heart block. So to describe this, when I think about weak muscle problems, I think poor conduction, poor communication within the muscle itself, and that's a good way to think about heart block. Signals just aren't quite making it. So again, when we're thinking about weak muscle problems, clients with hyperkalemia can also experience things like ascending paralysis, or paralysis that starts in the lower extremities and works its way up. It's similar to the pathology of Guillain-Barré, if you're familiar with that. Alrighty, so let's talk about complications. Our biggest thing when it comes to hyperkalemia complications is we're thinking about our cardiac issues, we're thinking about our hearts. We're most worried about those fatal dysrhythmias that can result from hyperkalemia. So if hyperkalemia persists for too long, if it goes on for too long, our client can progress from those peak T waves that you see in the ECG strip to VFib and eventually even to asystole. So let's think back to those weak muscle problems that we see in hyperkalemia. We have weak conduction, we have weak communication. All that put together really paints a clinical picture of asystole, essentially that total breakdown of our heart muscle and our heart electrical system. Okay, so that was a scary potential complication of hyperkalemia. Now let's talk about, as nurses, what's the treatment? What can we do to intervene and hopefully prevent this? So first things first, let's make sure we're monitoring very frequently. We want to monitor these electrolyte levels. So we want to get our baseline. We want to repeat our levels per our hospital protocol, per our provider orders. order and make sure that we're trending in the right direction. So again, we're hyperkalemic, so we want to make sure we're trending down back into a normal range of potassium. We also, because there are potential cardiac dysrhythmias that can result from hyperkalemia, we want to make sure these clients are hooked up to a continuous cardiac monitoring. And then if ECG changes start to happen, we want to give meds that help to stabilize those cardiac cells. Most important would be IV calcium gluconate. I'm going to say that again, IV calcium gluconate. Hint, hint, I'll give you a wink that will come into play later. But pretty simply, we just want to help to decrease potassium levels after we control those cardiac manifestations. So after we control the cardiac manifestations by giving that IV calcium gluconate, if there are ECG changes, we would then move to decreasing the serum potassium. And we do this by increasing potassium excretion. So we talked earlier a little bit about how those kidneys help to excrete potassium. So we're going to give things like a potassium wasting diuretic, like a furosemide, which is also called Lasix. And we're going to give things that also get rid of it through the GI system, so like a K-oxalate that helps to get rid of excess potassium through the GI or the gastrointestinal tract. However, if our kidneys are impaired, we know they're not properly able to filter our blood, so we may need to advance to the point of dialysis in the case that those kidneys are just not working correctly. So essentially dialysis, to briefly go over this, this is a machine that takes over for the function of the kidneys. It does it mechanically to help filter the blood to get everything back into a normal range because the kidneys at this point are impaired or unable to do it on their own. Things that we also do, we would potentially give insulin. So we're going to circle back to insulin. We're not done talking about that, even though you may wish that we were. But we said earlier that insulin helps to drive glucose back into the cells and potassium back into the cell with hyperkalemia. So a hyperkalemia protocol in most hospitals will usually involve some kind of insulin administration. We know that we can give regular insulin, only regular insulin IV. So that's a big safety thing to know about the NCLEX. This NCLEX is a test of safety. It's making sure they are preparing and putting new safe nurses out into practice. So only regular insulin will go IV. And we may need to add some IV dextrose as well with this because we don't want to make our clients hypoglycemic or drop that blood sugar too low with this insulin. So we want to make sure we are supplementing with some kind of IV dextrose just so we're closely controlling that blood sugar or blood glucose level. Alrighty, and last but definitely not least, we have nutrition. So a client that's hyperkalemic is going to need to be educated on ways to avoid potassium in their diet. They're going to be on a low potassium diet, which means they're avoiding things like bananas, cantaloupe, avocado, and spinach. We're going to talk and brush on this a little bit more when we cover hypokalemia, which, speaking of hypokalemia, we have now completed our hyperkalemia part of the lecture, and we can switch gears. So kind of revamp, think we were hyperkalemia, we are too much potassium. Now we're going to switch gears into too little potassium or hypokalemia. Alrighty, so speaking of diet, we're now going to switch to a slide that shows a potassium-rich diet. And a good way to remember this is to think fast or think FAST. And so this is a great, again, any visual reference we put up here, you guys are free to go ahead, screenshot it, save it for your own future studies. I know I'm a visual learner and resources like this are really, really helpful. So go ahead, screenshot away. And a quick reminder, hypokalemia, again, low levels of serum potassium is going to be below that 3.5 level. So let's talk about the causes of hypokalemia. And the good news here is this is a little bit simpler than some of the pathology of hyperkalemia. So in the big picture, we don't have enough potassium. That means too much potassium is going out of the body or too much potassium is going back into the cell, but there's not enough blood or serum potassium. So let's visualize a client sitting in a bed in the hospital. And a good way to think about hypokalemia is the starting point is going to be the stomach or the abdomen. So anything that comes up, like emesis through vomiting, or maybe if they have an NG tube dissection, this can be a cause for hypokalemia, as well as anything going down, like diarrhea or increased urination. Things like meds, like a potassium wasting diuretic that makes you void a lot, a furosemide, a Lasix. This can be a cause for hypokalemia, as well as conditions that increase urination or cause polyuria, such as hyperaldosteronism. All right, and we can also think about conditions that shift potassium into the cell from the blood. So think back to our treatment for hyperkalemia, which was insulin. Too much insulin can shift too much potassium into the cell and cause hypokalemia as well as hypoglycemia. And remember, potassium and glucose are pretty closely related. So for hyperkalemia, we also talked about metabolic acidosis. The opposite is true for hypokalemia. hypokalemia, we're gonna be more in the range of alkalosis instead of acidosis. So again, since hydrogen and potassium are directly related, when we have alkalosis, we have a low hydrogen ion concentration and therefore low potassium. Alrighty, so this gets a little bit confusing, but you all are doing such a great job of following along. Now that we know the causes of hypokalemia, let's switch into some of the clinical features. What are these clients going to present as? So what we'll see in a person with hypokalemia, we can visualize too much potassium in our cells and not enough in our blood. So if our cells have too much potassium, essentially we can think of them as being jittery. It's kind of a similar to feeling to if anyone here has ever had too much caffeine, maybe too many cups of coffee, too many Celsiuses. It's going to be fast, it's going to be jittery. So our heart is a muscle, and potassium really affects our muscle conduction. And when we're thinking jittery and glitchy like that with hypokalemia, some ECG findings that we may see are PACs or PVCs, meaning premature atrial contractions or premature ventricular contractions. Our atrium and our ventricles they're excited, they're jittery, they're glitchy, and they're firing too fast. So these may be some ECG changes that we see. Clients can also experience dysrhythmias such as VTach and VFib. So again, in VTach, our ventricles they're going way too fast, they're super glitchy. We can also see muscle cramps with hypokalemia. And remember, a good way to remember this overall is hyperkalemia was that weak muscle. Hypokalemia is that jittery, twitchy muscle. Other findings we can see in our hypokalemia clients will be smooth muscles in our GI system can be affected. So we can see like clients that have nausea and vomiting, they can have decreased bowel sounds, they can have constipation. Alrighty, so now that we're through all of these complications and things that we can see with hypokalemia, what do we do as nurses? How can we treat this? So as always, first thing is first, we want to monitor our electrolyte levels. So we want to get our baseline. We want to collect repeat levels per our hospital protocol or our provider order. Again, make sure we're trending in the right direction. So now we're on the hypokalemic side where we do not have enough potassium. We want to be trending upwards. We want to be going back towards that normal range. Alrighty, because we know that we can have those dysrhythmias and those ECG changes, we want to make sure these clients are on continuous cardiac monitoring. We know that potassium can affect the heart. And we also want to do things to help stop potassium from leaving our body. So we may need to avoid those potassium wasting diuretics like the furosemide or the Lasix and switch that for a potassium sparing diuretic like a spironolactone. We want to stop any GI losses of potassium. So if a client is experiencing diarrhea or vomiting, we may want to give an antiemetic like an ondansetron or an antidiarrheal like a loperamide, a Lamodal, something like that. And most commonly what you do is we correct the electrolyte imbalance in order to correct the hypokalemia. In this case, it would mean administering potassium chloride. Now here we have a big kind of a red flag. Our potassium chloride is a high alert medication. There's a few things you need to know so that we can administer this medication safely, because again, we know our NCLEX is a test of safety. So potassium chloride is never a medication that we give IV push. We do not give potassium chloride IV push. And I will say that one more time, we do not give potassium chloride via IV push. Remember that this can be fatal to our heart muscle. Our cells can't navigate that quick influx of the potassium. It can be fast and it can be fatal, which is why we don't give potassium IV push. We can give potassium orally or via IV piggyback. If we're giving it IV piggyback, make sure we're never giving it greater than 10 milliequivalents an hour. Potassium is a vesicant. It can really irritate that vein. So we want to make sure when we are giving it, we are monitoring the IV site for edema, for erythema, for any signs of infiltration. It can also be really painful, especially to our older clients that have maybe more sensitive veins and skin. So we're going to want to do things by maybe give a hot compress or a warm compress just to help with that discomfort. And we're going to really closely monitor the infusion rate. In some cases, it may be indicated to turn it down to a slower infusion rate, especially in the case that the client's having a lot of discomfort. Alrighty, so our last point to hit is going to be diet. So we want to do that potassium-rich diet. So again, all the foods we were avoiding in hyperkalemia, we now want to encourage in hypokalemia. So again, we're thinking fast. We're thinking FAST, fish, avocado, spinach and strawberries, and tomato. This fast or think fast is a great mnemonic to remember a couple of the foods that we know are super high in potassium. Alrighty, so way to go, you guys. You did it. We made it to the end of the lecture content. You did so well. Electrolyte balance, fluid balance, things like that can be so tricky, but you guys really hung in there, and I am so proud of you. So let's move on to question number 1 and see what we've learned today. So in question 1, the nurse is caring for a client with chronic kidney disease. The nurse notes tall, peak T waves on the continuous cardiac monitor. Which of the following actions would be a priority for the nurse to take? Option 1, administer IV calcium gluconate to the client. Option 2, teach the client to limit dietary intake of potassium. Option 3, request a prescription for oral sodium polystyrene sulfonate for the client or Kxalate. And lastly, option 4, prepare the client for placement of a temporary catheter for hemodialysis. Alrighty, I will go ahead and give you some time. Go ahead and let me know what you're thinking. And I see some of you said I was talking too fast. I will try to slow down. Potassium makes me excited, so I got too jittery just like we did in hypokalemia. Alrighty, and in the meantime, let us know what topics you all want to see. Again, we really want to make sure we're hitting all of the content and the things that you guys want to see us do. So drop in the chat. Do you want ECG? Do you want OB? Do you want maternal health? What topics do you want to see us put on? We've recently gotten a lot of requests for mental health, for OB, and for peds, and we have done our best to really try and incorporate that into our schedule. So if there's anything else that you really don't think we've covered enough, let us know in the chat. I see ECG. I see, let's see, mental health, cardiac meds, OB. Oh, another OB. Wonderful. So thank you so much for sharing. Now let's go ahead and dive in. I see a lot of answers that have come in, and mostly I do see the correct answer. So let's go ahead and we'll dive into the explanation here. So our correct answer was option 1. Way to go. Good job, guys. Our correct answer, of course, is to administer IV calcium gluconate to the client. And why is this? So in the question, it's always so important to read that question in depth. We see that the nurse notes tall peaked T waves on that ECG or the continuous cardiac monitor. So we're worried about cardiac complications. When there are ECG changes with hyperkalemia, which is what causes those peaked T waves, it's going to be a priority for the nurse to administer that IV calcium gluconate to help reduce that myocardial irritability, protect the myocardium from potassium-induced dysrhythmias. Again, we're always thinking ABCs, airway, breathing, circulation, and having dysrhythmias, that really affects the C, or the circulation of those ABCs. So this is our first priority. Remember, this is a priority question, so it doesn't mean that we wouldn't do some of the things in the questions. It just means that one, we would do first priority before we did any of the other interventions. So let's look at the other incorrect options, options 2, 3, and 4. So teach the client to limit dietary intake of potassium. Again, in a hyperkalemic client, we would want to teach them to limit their intake of potassium, but this is not going to trump or be more important than a cardiac complication. This would kind of come later in the process. 3 and 4, so 3 is request a prescription for that Kxalate for the client. Again, we would want to help to excrete potassium, but our first priority is to control circulation, that C of the ABCs, and this is not more important than controlling these potential dysrhythmias. And lastly, prepare the client for placement of that temporary catheter for hemodialysis. So in this client, they have chronic kidney disease. So again, we may need to progress to the point of hemodialysis, but it's a higher level of intervention. First and foremost, we want to control those dysrhythmias. So again, we would do number 1 first, and preparing them for hemodialysis, if that's indicated, would come a little bit later in the process. Alrighty, so again, our correct answer was option number 1. Let's go ahead and move on to our second and final question of the day. So the nurse is collecting data from a client with heart failure who is receiving furosemide. Which of the following findings would indicate the client is experiencing an adverse effect of furosemide? Alrighty, our options are going to be option 1, 2+ pitting edema in bilateral lower extremities. Option 2, muscle cramps during ambulation. Option 3, fine crackles in the lung basis. And option 4, increased urinary frequency. Alrighty, drop your answers in the chat. Let us know what you're thinking. And in the meantime, just to give you a little view into what we're going to cover this week, we will be back at 3 p.m. Central Standard Time on Wednesday to do a question drill. We'll be going live at 2 and 3 p.m. Central Time with mental health questions. So everyone that requested our mental health questions. It is your time. Tomorrow is your day. We will be doing that at 2 and 3 p.m. Central Time. And we'll be back on Thursday with Nurse Incoli to do a GU or a genitourinary question drill. So make sure you're staying on for those. We have some really great content for you guys. I think you'll find it really helpful, especially if you struggle with mental health concepts or GU concepts. These are going to be great things for you guys to attend. Alrighty, so let's go ahead and look at the chat. And I see a lot of 2s here. And the good news is that 2 is indeed our correct option. So way to go, you guys. So let's look at the question again. Client with heart failure receiving furosemide. So this is a diuretic. We know that. It is not a potassium sparing diuretic. It will get rid of potassium. So we know this client on furosemide has a proclivity for the potential to be hypokalemic or not have enough potassium. So option 2, our correct option, muscle cramps during ambulation. Because we're not sparing that potassium, we may take too much potassium off, and we know that hypokalemia can lead to muscle cramps. So that's why this is our correct option. Option 1, 3, and 4. Let's dive into these a little bit more. So again, we have a client with heart failure. We know in heart failure, we can have volume overload. So a 2+ pitting edema is more going to be an effect or a manifestation of this heart failure rather than an adverse effect of the furosemide. And here it's so important to make sure we're reading the questions in full, because we're not asking for manifestations of the heart failure. The question is asking for adverse effects of furosemide. So again, 2+ pitting edema would not be the case. This would not be an adverse effect of furosemide. It would be a manifestation of chronic heart failure. Again, 3 follows suit with that. This is more a sign of volume overload, but not an adverse effect of furosemide or Lasix. And lastly, increased urinary frequency. Again, urinary frequency, if we have a diuretic that's getting us to diurese and get more fluid off, we're going to expect to be going to the restroom a little more often. So again, increased urinary frequency is expected. These clients are diuresing. So this is not an adverse effect. This is an expected effect. Again, our correct option was option number 2. Way to go, you guys. You did so well today. That was a tricky question, but you all did so well. Alrighty, and let's go ahead and we'll go to our uworldnursing.com slide. Reminder that this uworldnursing.com is a great home base for everything that you guys want to see. It gives you the schedule for the next 3 weeks of content so you can see what we plan to do. Thank you so much for joining. Again, all of these lives will be on demand on Facebook and YouTube, so make sure to check it out. We'll be back tomorrow at 3 p.m. Central Standard Time with that question drill, so make sure you tune in for that. It's mental health questions that we're going to be covering tomorrow. Make sure to subscribe and follow to @uworldnursing on your preferred social channel, and thank you so much for joining. I really appreciate it. See you guys next time.